Welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is Pediatric MS. This presentation features Dr. Teri Schreiner. Dr. Schreiner directs the Neuroimmunology Clinic for Children, a multidisciplinary clinic for the care of children and adolescents with MS. This webinar is scheduled for 1 hour. The first 45 minutes will be a presentation from Dr. Teri Schreiner. If you missed something on a slide, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We'll reserve approximately 15 minutes at the end to answer questions from the audience. Please submit your questions throughout the presentation by typing them into the chat window on your screen at any time. We will answer as many questions as time allows. With that, we'll turn it over to Dr. Schreiner.
Hello and welcome to this webinar about pediatric onset multiple sclerosis. I am a physician here at the University of Colorado and Children's Hospital Colorado, and am happy to share with you my passion for discussing the presentation, progression, and treatment of multiple sclerosis when it presents in childhood. I will be going through a series of slides addressing these issues, and I would encourage you as we're going through that if you have questions, please do type them into the screen on your left so that I can address them perhaps in a real-time manner, and if not, then at the end of the presentation. We will have plenty of time for questions and answers. Part of what I do in addition to treating children and adults with multiple sclerosis is clinical research. And so this means that I will have the following disclosures. I have worked with companies, Biogen, Teva, Novartis, the National Institutes of Health, and a company named MSDX doing clinical research pertaining to multiple sclerosis, both in children and in adults. And I have received speakers' fees from Genentech and the Multiple Sclerosis Association of America. What I'd like to do first, before getting into pediatric onset MS, is to visit the larger topic of multiple sclerosis. What do we know about the disease in adults? What is the biology behind it? And once we establish that foundation, then we'll talk more specifically about how this is different when multiple sclerosis presents in childhood. Our hope in studying this, in learning from our patients, is that if we are able to figure out why this adult disease presents in childhood, we may be able to figure out why it happens in the first place. But we'll talk more about that as we go. We'll also address the clinical course. So what does it mean to children to be diagnosed with MS, and what can we anticipate for their adulthood based on this early diagnosis of MS? And then we'll talk about the available treatments, including some upcoming treatments that are coming and exciting for us. So the diagnosis of multiple sclerosis is relatively simple. When you come down to it, what it means is there is a disorder of the immune system that is attacking the brain and the spinal cord and causing symptoms that depend on where the immune system is attacking. This attack, unfortunately, does not just happen once, but is a chronic disease. And so the attacks, discrete episodes in which the immune system attacks the nervous system, we call relapses, and relapses happen over time. What happens when the immune system attacks the brain and the spinal cord on the cellular level is that we see that the axons, the projections that come from neurons and travel within the brain, the spinal cord, and then make connections that go throughout the body, they are damaged by the inflammation that the immune system triggers. The screen in front of you shows on the left an axon, a nerve fiber that has a nice, robust, thick myelin sheath. The myelin sheath allows the electricity of that nerve to flow quickly and efficiently across the nerve fiber. When the myelin has been attacked by the immune system, it looks like what you would see on the right side of the screen. It's thinner, it's damaged, and what this means to the axon, the nerve fiber, is that the electricity does not pass through that area as efficiently. In some cases, the damage can be severe enough that the actual nerve fiber is damaged or severed itself. Now, as I've mentioned, the diagnosis of multiple sclerosis implies or mandates actually that it is not just a one-time event. There is dissemination over time, and that we haven't found another explanation for the episode of neurologic dysfunction. The second criteria is dissemination in space, and what this means is that it's not just one area of the nervous system that is getting attacked. It may be the left side of the brain at one event, it might be the spinal cord in another, it could be the optic nerve for a third, but there is a change in the location in which the immune system attacks. Now, as I just mentioned, we're talking about dissemination in space. And this slide here is an axial image of a brain as seen in MRI. And the white spots that you see refer to different areas within the brain. And this is the dissemination in space. So again, one area would potentially represent an immune attack at one time, and then another spot may pop up in a different area at a different time. This is dissemination in space and dissemination in time. We care about this because sometimes the immune system attacks a part of the brain that doesn't manifest clinically, meaning there can be inflammation going on in the brain that doesn't cause the patient to have any problems. And this is the reason why we do MRIs. So the last slide is a schematic illustrating how complex the immune system is. So there are many things that we know about the biology of MS, about how this happens. But there's similarly many things we do not know. But one thing we are certain about is that there are many different players that participate in this immune attack. It starts with a disruption of the blood-brain barrier. And what you see on the left side of the screen is just a transection of a blood vessel, as you might see, or a schematic of what you might see in the brain. Now, the inside of that blood vessel has a very tight barrier called the blood-brain barrier that really regulates what is allowed into the brain. So many things can pass through the blood vessel itself, but only very particular things can cross that blood-brain barrier to get into the brain. If that barrier is disrupted, as is the case in what we see with multiple sclerosis, then a host of additional immune system signals are sent out that kind of further the inflammation in that area. So the first thing we know in MS is that the blood-brain barrier is damaged. That causes, triggers a release of inflammatory signals within the brain, which then sort of propagate as inflammation within that particular area. And there are different cells involved. B cells and T cells are important because those are targets of where of the medicines that we use, but additional cells like macrophages and microglia and astrocytes can play a role as well. So most MS. We know that most multiple sclerosis presents in adulthood. And what we see most commonly is a Caucasian woman, oftentimes of Northern European descent, in her 20s or 30s, presenting with discrete neurologic deficit. In many cases, it is an optic neuritis. It's a difficulty with vision in one eye, but it can be any function of the immune system that has been attacked. significantly more women are affected than men, but men are affected by this. And although most people are diagnosed in their 20s and 30s, it is possible to become diagnosed, to get a diagnosis, or to present much later, and as we know, of course, earlier. There are different terms used to describe the pattern of disease in multiple sclerosis, and most people have the pattern that we refer to as relapsing and remitting multiple sclerosis. This is what we've described, having discrete episodes of neurologic deficit disseminated over time. But there is another type of multiple sclerosis that we do not see in children, but we do see in a minority of adults, and that is referred to as a progressive disease, progressive decline, either primary progressive MS or secondary progressive. Now, as of yet, there is no cure for multiple sclerosis, but we do have many effective treatments that can control the disease. Many of these have been, or most of them, all of them, have been studied in adults. Now there is a movement afoot to test these in children as well, and we'll come back to that in a little bit. So focusing more specifically on the pediatric onset MS. It's a relative rare occurrence for a child to be diagnosed with MS. But when we look at all of the patients with MS in the country, we estimate that it's somewhere in the 5%, or some say even as high as 10% of all patients with MS who are diagnosed younger than 18 years of age. Most of those children are in the post-pubertal age. So they're in that sort of 12 to 13 up to 18 age range. We do see a minority, though, that are diagnosed before the age of 10, and they have a very particular clinical presentation that we'll return to. As I've mentioned, the vast majority, if not the entirety, of pediatric multiple sclerosis is of the relapsing and remitting pattern, indicating discrete episodes of neurologic change over time, not the progressive kind, which may not have as distinct episodes. What we see in children is that the younger children, when taken as a group, have a more equitable distribution between boys and girls than what we see in adults, where there is a far greater female predominance. But as we look at the age range of the children with pediatric MS, when they are diagnosed older, they have a sex ratio, a female to male ratio, that begins to look more like what we see in adulthood. Unfortunately, we see that children, when they are diagnosed with MS, have a much more inflammatory disease, meaning that the average relapse rate in an adult may only be one every 18 to 24 months, one relapse every 18 to 24 months. But that in children can be closer to 2 to 3 per year, so a much more frequent inflammatory attack on the nervous system. We also see in children that the areas of the brain affected are different than what we see in adults, with more common or more frequent involvement of the brain stem, the part that connects the spinal cord to the hemispheres of the brain, or the cerebellum that controls our balance at disease onset. The next point is an important one. Now, encephalopathy is a term that refers to disruption in cognitive function. It can be as dramatic as psychosis, seeing things crawling on the walls that aren't there, sometimes hearing voices, to an intense paranoia. It ranges all the way to just sleeping a lot, sleeping 23 hours a day, or having a confusion that is atypical for that child. Encephalopathy does not generally occur with multiple sclerosis in adults, but it can occur as a presenting symptom or a symptom in combination with other neurologic deficits in children. And we see it more often in the young children, children younger than 11. And this is an important distinction because there are other diseases in childhood that can present with encephalopathy as well. And so when a child presents in a confused or altered mental status, it really is important to look at all of the different symptoms to make sure that the encephalopathy is not a sign of a different disorder. Now, children have a very robust capability of repairing their nervous system. And so even though they may have more relapses per year than an adult, they do really well generally in terms of recovery. It might take a while, but most children have a capacity for repair and for compensation of deficits that exceeds that of adults. And so even though they're having more difficulties, more frequent difficulties, they can recover and look pretty good in the short term. But this is not something that we should take for granted because we know that even though the children recover from the relapses well in the early years, there is only a finite reserve. And so the more attacks occur early in the course of disease, the more likely that patient, that child who is now growing into an adult, is to have more difficulties, more disability. Let's talk for just a little bit more about how the presentation of multiple sclerosis differs in the very young children versus the older. So the suspicion is that in childhood, hormones play a role in how the patient presents. And this is data that we are or that we have observed previously, but also extrapolated from what we know in adults as well, which is that hormonal status does influence multiple sclerosis. So hence the division between prepubertal and postpubertal children. As I've mentioned, the young kids, the prepubertal children, can present with encephalopathy, that confusion, severe fatigue, psychosis, and that this is different. This is a distinguishing feature from what we see in both the older children and what we see in adults. There are similarly differences in the laboratory studies that we as clinicians use to help us make a diagnosis. And although it's no longer part of the formal diagnostic criteria, oftentimes lumbar punctures or spinal taps are done in adults to help us understand whether or not there are signs of inflammation in that spinal fluid, which we refer to as oligoclonal bands. And it's almost the rule in adults that these oligoclonal bands will be present. But in very young children, they may not have these markers of inflammation called oligoclonal bands, but still have the diagnosis of multiple sclerosis. So that's an important consideration. As the children get older, as they go through puberty and approach that designation of adulthood that comes at 18, their cerebrospinal fluid begins to look more like that of an adult, and the frequency in which we will see oligoclonal bands increases. Now, the MRI appearance can vary with age as well. So what you see on the slide in front of you is the same patient taken at two different time points. The two images at the top are pictures of an MRI at diagnosis with multiple sclerosis, and this is a young child, a prepubertal child. And what you can see, particularly in contrast with the images below, are areas within the brain that are whiter than what you see below. These areas of whiteness designate the inflammation in the brain. And we're looking at it from two different perspectives. On the bottom, this is just 3 months later, that same child had these repeat images taken, and we see those areas of white have significantly diminished. And this is something that differs from what we see in the post-pubertal child, as you'll see on the next slide. So again, the top two images are images taken at the presentation, initial presentation of multiple sclerosis, and then 3 months later below. And in contrast to the prior images, you see that the 3-month post images still have a number of white spots that sort of denote the inflammation, and we know some of the damage that occurs from MS. The significance here is that the young children probably have a more robust repair, but also that the inflammation may differ between the young children and the older children, with the younger children having more inflammation that is readily resolved, whereas the inflammation that we see in the older kids may be of more long-standing and permanent status. So what do we know about the cause of multiple sclerosis? Well, there have been several studies, both in adults and in kids, looking at different risk factors for pediatric MS. And the next couple slides get a little detailed, so I want to go to the next one. Here we talk a little bit about environmental factors. So as we think about what causes MS, there's no smoking gun, though many have looked. There's been no particular virus that has been identified or any other particular cause that is the reason that somebody gets MS. But what we have found in our studies is that there's some combination of both genetic and environmental contributors to disease. Within the category of environmental factors, we know that some viruses, like the Epstein-Barr virus, are found in almost 100% of patients with MS, both adults and children. This is a much greater percentage of or prevalence of the virus than what we see in the general population. So we think that that has a role to play, that somehow increases the likelihood of developing MS. Whereas other viruses, like the cytomegalovirus, seem to have a protective effect. So in other words, contracting CMV, the cytomegalovirus, may actually be protective against developing multiple sclerosis in childhood or later. Now, the other areas that we think about within the environment are based on what we have observed in doing epidemiologic studies of children with MS. We know that there is a higher risk if the child grows up in a home with smoke. We know that vitamin D status, particularly low vitamin D in childhood, is a risk factor for disease. We know also that if you that once you are diagnosed with MS, a low vitamin D status, a low vitamin D level, is correlated with higher disability. We don't know that it's causal, but we know that there is that association. We also know that obese children have a higher risk of multiple sclerosis than children who are not obese. And let me talk just a little bit about the genetic risk factors. So we know that first-degree family members of patients with MS have a higher risk of developing multiple sclerosis, about a 5% lifetime risk. That is greater than what we see in the general population. But we know that genetics are not the only thing that contribute to risk for MS, because we have observed in monozygotic twins, so twins that have identical genetic makeup, there is only a 25% concordance that if one twin has MS, that the other twin will have it as well. And if we thought, well, the cause is undoubtedly entirely genetic, then we would expect those two individuals with identical genetic material to have 100% risk of MS. So if one had it, the other one would certainly have it. So we know that is not the case. So clearly there is a contribution of genetics to the risk of MS, but that is not sufficient. One of the areas of genetic inquiry has been into haplotypes. These are markers on white blood cells that allow the white blood cells to talk to one another, either in a stimulatory or calming, inhibitory manner. And there are certain types of haplotypes that are seen much more commonly in patients with MS. And they're listed there on the screen. But these are genetically coded types of proteins, glycoproteins on the surface of white blood cells that may have a role to play in promoting inflammation in the immune system. Now let's go back. Yes, let's talk about outcomes. So one of the ways in which we measure function in a patient with multiple sclerosis is through something called the Expanded Disability Status Scale. It is a very formalized way of taking the results of the neurologic exam and quantifying them as a proxy for disability. And there are many things that are challenges with this grading system, but for research it does allow us the opportunity to try to differentiate patients with MS who are severely affected from those who are not. And the scale goes from 0 to 10, and 10 is death due to multiple sclerosis. And we're not going to, which by the way is very unlikely, but we're not going to talk about all these levels, but I will draw your attention to level 6. So 6 is going to be important as we look at the subsequent slide, and this is the point at which walking assistance is needed. So either a cane or a walker is required to walk a distance of 100 meters with or without resting. So now let's look at the next slide. This is information that came from a natural history study of patients, pediatric patients with multiple sclerosis in France before there was treatment available. And we're just going to focus on those middle two panels. Let's go to the next slide. So what we see, the panel on the left is the percentage of patients on the y-axis compared to years from onset of multiple sclerosis to getting to a point of needing to walk with a cane. And so again, years from onset of disease to needing to walk with a cane. We see that in the childhood onset population, those number of years is about 28. This is a longer period of time than what we see in the adults, where that's only 19.7 or so on average years. But don't infer that this means that childhood onset MS is benign, because let's look at the next slide. The next image on that same slide is the percentage of patients on the y-axis compared to the age at which these patients start walking with a cane. And what we see is that the childhood onset patients need to walk with assistance on average in this one cohort at 42 years of age. This is in contrast to the adult cohort where they were walking with a cane at 54.8. So the children are needing to walk with assistance at a much, I would say, younger age, an age at which people are in the prime of their life, working, building families, if untreated, compared to the adult onset cohort. And so I offer this as what we call natural history data. Nowadays, we would not withhold treatment from patients just to see how they develop over time. This data came when there wasn't treatment available. But what it has taught us then is that this disease untreated can result in disability on average 10 years earlier for childhood onset MS than for adult onset MS. One of the other outcomes that we are vigilant about tracking is the cognitive outcomes. So we know that MS over time can affect walking ability, but how does it affect our functioning, our cognitive functions, the thinking, attention, and memory? And this is a study from a little while ago, but what this study shows is that very early in the course of disease, only 19 months after diagnosis, a third of the patients in this cohort already had deficits in areas of attention, memory, and confrontational naming, which is just seeing a picture of something and being able to tell you what it is. And so this, I think, is our call to action. We can't have children with multiple sclerosis in school unable to maintain their attention, their memory, their naming, their math. This is, the time in life when they are meant to be absorbing as much information as possible. And this is, for me, a strong motivation to treat, to improve the cognitive outcomes of this population. Now, the bottom 2 points are noteworthy as well. Which is that the patients who had difficulties in their cognitive functioning also had higher EDSS scores, so more disability, a greater number of relapses, and a longer disease duration. And so we know that the longer the disease goes on untreated, the greater the likelihood of all of these things. Cognitive difficulties, higher disability, number of relapses, more relapses. And unfortunately, the difficulties that we see in the pediatric population expand beyond just cognitive as well as motor function. We see up to half, and sometimes I wonder if it's even more, with depressive symptoms. And depression is something that has been well studied and known to occur in the adult population. This is not just because having a chronic disease is depressing and is a weight for children and all patients to bear, but also because we know the multiple sclerosis affects the function of the brain at the cellular level with signaling between neurons in a way that is more prone to promote depression. It changes the biology of the brain. So what do we tell patients and their parents about pediatric onset MS? So one, we say, okay, we know that children have a very inflammatory disease. There are a greater number of relapses if untreated. And the more relapses you have, particularly in the first 2 years, the worse the prognosis, the greater, and said in a different way, the greater the likelihood of disability later. And so it's important to treat relapses early. We also counsel them that cognitive difficulties are common and that we need to look for them. And we look for them through formal neuropsychological evaluation, which is rigorous testing of how the brain is working from a cognitive standpoint. So I've mentioned the different outcomes of untreated pediatric MS. Let's talk a little bit about treatment, therefore, of children with MS. The treatments fall into three large categories according to means of administration. The oldest medications that we have are all injections, and they are, with the exception of the last one, teclistamab, older drugs that have, in some cases, taken on new formulations and are injected at differing intervals, either every day, 3 times a week, every other day, weekly, or in the case of teclistamab, longer. But they are all injections which have an efficacy in general somewhere around the 30% range, meaning that 30% of relapses will be prevented with the use of these medicines. And there are other ways of measuring that according to MRI categories as well. But let's talk about the second major category, which is that of oral medications or pills. These are medications that have become available within the last 5 to 7 years, Tecfidera, fingolimod, and Aubagio. They are either daily or twice daily medications. They have, in general, a higher efficacy. So the Tecfidera and fingolimod have about a 50% efficacy, Aubagio a little less. And they have the convenience of oral dosing. It's much easier to convince a child to swallow a pill than to take an injection. But they do have a different side effect profile that requires frequent monitoring as well. And the last category, the infusions, are Tysabri, a monthly infusion, and rituximab and ocrelizumab, rituximab being the older version of ocrelizumab, which is a drug we anticipate soon, which is infused every 6 months. The infusions have the benefit of a higher efficacy. They work better at preventing relapses and hopefully at preventing disability long term, but they do have a higher side effect profile that requires vigilance with monitoring as well. So I've spoken a bit about these two medications, the oral medications. And I think in the interest of time, I will skip over that, and I will talk on this slide just a bit about rituximab as it pertains to ocrelizumab, which is one of the medications that we are expecting soon to receive FDA approval. So rituximab is a drug that has been FDA approved for rheumatologic disorders and B-cell lymphoma for some time. It's a well-established drug that is used for those disorders as well as for others, off-label. We have used rituximab to treat multiple sclerosis both in children and adults for some number of years, but this has been an off-label use. The new medication, the new formulation, I should say, of rituximab, which is called ocrelizumab, will be FDA approved for use in multiple sclerosis, thereby eliminating some of the difficulties to getting the drug for our patients. In general, rituximab and what we know of ocrelizumab is well tolerated. About 1/3 of patients will have an infusion reaction causing symptoms of, scratchy throat, flushing, sweating, feeling awful, nauseous, that is treated with medications during the time of the infusion. And 2/3 of people will have no difficulty. There are other side effects that we watch for over time, mostly in the area of infections, which can be more frequent with rituximab. And before we summarize, I want to take a point to recognize that we've spoken a lot about how the pediatric patients with MS do as individuals. But this really isn't fair when we recognize that children are growing up within a family system. And so the diagnosis of a chronic illness in a child doesn't just affect that child. It affects sibling relationships. It affects parent relationships with the child, particularly if the parent is the one having to administer an injection or be the one who's always saying, take your medicine, did you take your medicine, so forth. But it can also affect relationships between parents who may have differing ideas about how to adjust to and manage a chronic disease for their child. And it's not uncommon to have siblings say, well, how come Joey gets to miss his exam and go to the hospital when I have to stay and do this, or so forth. So really understanding that the children with MS exist within a system and that we need to support the whole system, I think is paramount for the health of the child, both directly and indirectly. And so a few summary points. The children with MS recover very well from attacks early in disease, but particularly if untreated, they can reach disability at a younger age in adulthood. And hopefully with our effective treatments, we are negating that possibility, but there is a strong argument to be made for effective early treatment of pediatric onset MS. We know that there are environmental and genetic triggers that are similar between adults and children, but we continue to study this area to try and understand if there is some disproportionate risk burden that would account for why this adult disease is happening in children. Then we may be able to help figure it out in adults as well. And lastly, of course, the psychosocial impact of this chronic disease is huge for the entire family. Here are a couple resources that I recommend. The top website is the Neuroimmunology Clinic for Children, which I run, and then, of course, the Rocky Mountain MS Center, mscenter.org, National MS Society.org, and the last one is the Multiple Sclerosis International Foundation that also has information about childhood MS. And at this point, I will pause. If there are any questions, I would be happy to address them now.
Thank you, Dr. Schreiner. I do have a question about what are some of the particular challenges of treating pediatric MS versus adult MS?
Okay, good question. Well, the first thing that comes to mind as a particular challenge for treating children is adherence. And what that means is taking your medicine, taking your vitamin D, getting exercise, eating a low-salt diet, eating vegetables. These are all things that we recommend for patients with multiple sclerosis, both young and old. However, when the disease occurs in a child, and I will more specifically say in a teenager, who by definition is exerting his or her independence against the world, convincing someone to take their medicines, get exercise, eat vegetables, have a low-salt diet, and take vitamin D, it's a lot to ask. And so what I observe, and one of the things that we've studied at our clinic as well as others across the U.S. and Canada, is what can we do to help teenagers adhere to their medication and to their lifestyle regimen that we know will help them. And it is difficult because this is as I mentioned, a time in life that is challenging for teenagers by definition, but then giving them or diagnosing them with a disease that they may feel that they have no control over can sometimes create behavior that is maladaptive, that is counterproductive. And so we take this on a case-by-case basis, but try very diligently and fervently to educate our patients so that they know what they need to do and they know the reasons behind it.
Question from the audience. Do you have an idea of how long it will take to get the new infusion FDA approved?
So for ocrelizumab, which is the new infusion that we are anticipating, we are hoping for FDA approval within the next few months. Now, I must caution that we've been expecting this FDA approval for quite some time. And so while we now have some information that it is closer than it has been in the past, I am sort of controlling my own enthusiasm by saying that. So we hope that it will happen either by the end of this year or first quarter 2017. If that occurs, the natural progression then would probably be another 3 to 4 month period in which the payers, the insurance companies, establish guidelines for how they are going to pay for it, and the drug company during that time will be figuring out how they are going to distribute the medication. And so although, or I should say, even if the FDA were to approve ocrelizumab in the next 6 weeks, let's say before the end of the year, I don't anticipate being able to prescribe this for several months afterwards.
What are some signs and symptoms that parents should be concerned about in children?
Okay, so for a child that does not have a diagnosis of multiple sclerosis, so for any child, I would seek care for any new neurologic symptom. And what I mean by that is weakness of one or more limbs, weakness in an arm, weakness in a leg, numbness. So numbness of an extremity or one side of the body, side of the face, particularly if it lasts more than 24 hours. Any visual deficit, and specifically loss of vision in one eye, difficulty moving the eyes, incoordination, sort of drunken sailor kind of walk. Any of those types of symptoms that occur in a child without any known disease, I think, should absolutely bring prompt the parent or adult to bring the child to care. And depending on what the symptom is, that would either be a trip to the primary care provider's office to start or to the emergency department, depending on the severity of presentation. What I tell my patients is that the patients who have a known diagnosis of either clinically isolated syndrome or pediatric MS is that if they develop a new neurologic symptom, weakness, numbness, incoordination, vision change, that lasts more than 24 hours and something that they have not had before, then they should call into our clinic so that we can discuss next steps. It is possible for all patients with multiple sclerosis to develop something called pseudo-relapses, which are return of old neurologic symptoms in the times of stress or fatigue or heat. And so symptoms that represent during any of those situations are less concerning than symptoms that have not been present before and last more than 24 hours.
In the presentation, we discussed the age of assistance needed for children diagnosed but left untreated. What would be the average age of assistance needed for children that are being treated for MS?
That's a great question, and those studies are ongoing, but I don't have a good answer for that yet. And the reason is these longitudinal studies. So the studies of what a teenager diagnosed with MS looks like at 40 are, by definition, 20 to 30-year studies. And so that takes a while, takes that long to get that data. And so we anticipate, we expect that the age of disability can be significantly postponed, if not averted entirely, by the use of highly effective disease-modifying therapies. But we don't actually know that yet. The studies that we have of disease-modifying therapies in children have really just, they're just getting started now formally. And the studies that we do have are of, 2-year duration or retrospective studies of doctors who have said, I've treated 30 patients with Tysabri and this is what I saw. So the best data will come with time, but that's hard to accept, that we won't have a good answer for that for 20 to 30 years. But I think every year that we study how our pediatric patients are growing into adulthood, the better idea of the trajectory we will have. And at this point, we're quite optimistic that with these highly effective therapies, we can dramatically improve the function of the child as they go into middle and older adulthood.
Thank you, Dr. Schreiner. You actually kind of just answered my last question. So I think we'll close it on what kind of success stories have you seen, or do you have any favorite stories to share with us?
Okay, great question. Well, I think that there are successes that I observe in clinic all the time, and it's highly variable according to the child. But in some patients, a dramatic success might just be getting the vitamin D level into a normal range, if that's been a struggling point. The stories that I like the best are the ones that start it just like the disease starts like a ton of bricks dropped. It's just an overwhelming burden, frequent relapses, hospital stays, need for rehabilitation that then can be effectively treated with medication. And then, it becomes just a bad memory, and the child goes on with their life and does not feel impacted by multiple sclerosis. I think in a sense the best successes are the ones where patients come to me and they just say, well, nothing's new. Joey's on the honor roll and he's playing soccer, and we show up and we get our MRIs every year and they've been stable. Those I think are the best successes, and I think that it's so achievable. We are so thankful now to have good medicines that actually allow our patients with MS to just live their lives and not have the MS alter that course.
Thank you very much, Dr. Schreiner, for taking time out of your day to talk with us and share your knowledge about pediatric MS. We've got contact information for the clinic up on the screen if you have further questions or you want to make an appointment.